Hi, I'm Brian Bezic and I'm a practicing PA. I practice in pulmonary medicine just outside of Boise, Idaho for the Terry Riley Health Centers. This video is on diagnosing and phenotyping COPD. If you think about COPD, about 70% of the patients that have COPD, the cause is due to tobacco exposure, direct exposure to tobacco products. 30% don't have that direct exposure. They may have secondary, secondhand smoke exposure, possibly occupational exposure, and there is a genetic form of COPD called alpha-1 antitrypsin deficiency that we should test every COPD patient for, as it may be playing a role in their disease process. For our patients with COPD, about a third have chronic bronchitis, which means they have a cough for 3 or more months in 2 consecutive years. About 2/3 have emphysema, indicated by alveolar destruction and gas exchange problems. When it comes to the diagnosis of COPD and the phenotyping, there's just 2 numbers I want you to remember. The first one is 0.7 or 70%. The GOLD guidelines, which help us understand how to diagnose and treat COPD, have that 0.7 is a criteria for the diagnosis of COPD. We need to get spirometry or PFTs. When those are done, we'll get an FEV1 over FVC ratio. If that ratio after bronchodilator is below 0.7, that is one of the major criteria for diagnosing COPD. It's not the end of the diagnosis, but it's a significant part and needs to be done. Once we have the diagnosis, we can then phenotype. Now I know, phenotyping is a big word and it can be intimidating, but I promise you it's not. With COPD, it's just one number. And it's a number you have in the chart already. It's the eosinophil count. Your patient, I'm sure, has a few CBC lab tests in their chart. If they do, and there was a differential done, you have the eosinophil count right there. Be sure to look back a couple of times because if the patient had been on oral steroids, that eosinophil count may be much lower than normal. Look back and see, do they have an eosinophil count at 300 or above? If they do, that's indicative of type 2 inflammation, and that inflammation may be playing a significant role in the patient's symptoms and how well they function day to day. For our patients with type 2 inflammation, there's good news and bad news. The bad news is that they tend to have more inflammation, more mucus production, and just generally have more symptoms than our patients with less type 2 inflammation. The good news is that inhaled and oral steroids tend to work better in that patient population. They're just more responsive because type 2 inflammation is more responsive to that. The other piece of good news is that newer therapies, specifically biologics for COPD, target that type of inflammation. So while they may present with more symptoms, have more exacerbations that tend to be more severe, we also have therapies that specifically target them. So when you get the diagnosis, that's that 0.7 number, and you look at their eosinophils in their chart, in their CBC that you already have, you can see, is it above 300? If so, type 2 inflammation may be playing a significant role. If it's far below that, then type 2 inflammation may not be playing a role. And we can now treat that as a treatable trait looking at the patient's phenotype. In the next video, we'll take a deeper dive into those treatable traits. We're also going to look at the GOLD guidelines recommendations for initiating and advancing therapy for COPD, always keeping in mind the diagnosis and whether or not the patient has that eosinophilic phenotype.